Hey everybody. I'm sorry. I'm trying to make sure that we get this last part done, and then we can return everybody to the normally scheduled programs. But this is, I guess, the first part is the meat and potatoes. I really wanted everybody to experience kind of what the residents, like just get a little topless version of what we do with the residents. This portion is where I kind of, when we were looking at how we could be effective in a workshop, the main thing is you want something to go home with. You want to walk away and say, all right, I have like some type of blueprint for how to do this at my shop. And so we'll talk about that here. For facilitators, really what you're trying to do is 5 things. I'm going to go through each one of these. One is identify. That's identifying good teaching cases with prominent underlying social factors. So each one of us in any shift can identify a case. But think about, like, over the course of maybe 6 months, there was a case where you saw so many different social underlying things and you're like, wow, I'd like to expose this to my residents or expose this to med students in a way that they can get the extracted portions or the raw distilled portions of social features that will make them better clinicians. You should be making mental inventories of this and constantly keeping this, just like you would keep a really cool case. Because we do the same thing when we're like, oh man, I had this case of rare X, or I have the visuals from this particular dermatological condition. We keep those same things. Well, why aren't we keeping the cases that are like really hard-hitting, multi-layered, where somebody, made a clear mistake and you're like, this was a particular equity issue. So I think that that's the goal, is identifying those cases on an ongoing basis. Deconstructing them. So you have to, as a facilitator, understand that there are component parts to the case. So we talked through this, the one that we just did with our sickle cell disease patients, realizing that as a learner, what's important is to see the pathology, to know the vitals, to know that this is a patient that's potentially critically ill, but also realizing that you need to have the other connective tissue too. Like, what makes this important? Because we'll see 1,000 chest pain patients, right? Deconstructing it so that you can find not just the clinical pearls, but the equity pearls too. And then from there, you distill it. This is realizing that each one of these cases has something that speaks to a larger theme in health equity, right? So today's theme, what we talked about mainly was implicit bias. We did a little bit of negative language in the charts. These 2 concepts are themes to the point where there's literally 50, 60 papers about each one of them that have come out in the last 3 years, 3 to 4 years, excuse me. But knowing that will give you the ability to create your context. Organizing it. So we shared the information. It was very linear. It allowed you to go through it. The context is where most people fall off, is if you don't have the literature, if you don't have the conversation or understand the tone, the national tone of these things, it can feel like you're missing things. But part of that comes from making sure that the themes are very prominent. So if you're going to talk about something like, obesity bias, knowing that, all right, I have to understand this at an elemental level, but where did it historically begin? How does it contextually affect the way that we deliver care? And what is the current literature around changing that? Like, having that in place will make the rounds a little bit more robust for the learners. And then finally, operationalizing what you learn, which is, we've done it in a 60-minute format. How would you be able to accomplish this in 30 minutes if that's all you had? How can you accomplish this in 15 minutes? And you just scale it based upon what's available. When I've done this in my morning rounds cases, this is like at our shop, basically on every morning, we have a zone that does teaching cases. And so instead of me teaching something that's going to be on their boards, I do one of these cases, but I make it very distinct, very clear. I'm like, okay, so what am I going to teach today? I'm going to teach, for example, I did one where I was trying to show them that you do not have to comply with law enforcement to give a tube of blood if they ask for it. That was my one thing that I wanted to teach them. So I brought the case, I distilled it down to these points, I went through the legal precedent for it, I showed them the case with the nurse who declined it and got fired and how she sued. I just continued to structure it, and then your teaching point at the end is, so what do? What is your personal tenet that you're going to hold to keep from potentially violating a patient's right or honoring your patient's right? That's just a micro example of how you do this. These 5 things as a facilitator, if you're able to keep in mind, I guarantee you'll be able to deliver something that is impactful and resonant. And then finally, you'll come up with kind of this outline for how to do it multiple times and scale it. Because that's where we're losing here, is most residents will get a pass at this once, but how would it look to get it every single year or multiple times a month or every time you come to a shift? How do you accomplish that? That's how you start to dial back some of those existing biases and work on the equity conundrum. There's a couple of questions that we have here. You want to take this, Moise?
Yeah. And one to sort of piggyback a little bit on what was said about being purposeful. In the sickle cell case example we use, there's obviously a lot of learning that can be had from that for like the NBME shelf exam, and what do they need to take away for clinical things. And while those will come up and they're important to recognize that there'll be things that you can sort of highlight and teach to as well. Again, we gave you sort of a scaled down version focusing just on the health equity issues. That'll come up when you're doing this during your sessions. It's important to acknowledge them and yes, sort of like say this is important too, but then elevate everything else to that level as well, right? Like if you had 5-minute discussion about the like pain choice, the pain medication choice options, and that's just sort of how it developed. Okay, fine, let it be, but then make sure that you allocate the right proportional time and attention to everything else that you wanted to as well, so that it still remains a very purposeful, like, that was good, that was important for us to review, but this is where we're at right now in our headspace. And so as Dr. Brown said, you want to find these common themes that are going to connect maybe one case to the other, and be able to create a thread, right? So that then when case 2 or case 3, or maybe if you do it in spaced repetition, then the next time you do it 2 or 3 months from now, there's a commonality that went with it. Yeah.
The other point I wanted to make about that is, I said it's like a rolling way of collecting these cases. One thing that I've thought was helpful is having like a team that does this as well. So for me, I have like other folks that have worked on our DEI committee. I'm like, hey, if you see a case, send it to me. If you're on a shift and you see something that's important that you think there are teaching points, send me the case and I'll help build this out. So that engine is extremely helpful. And then I said the other part about the pre-selected cases is I also worked with other students who were interested, other residents. I said, hey, what are some of the cases that you're hearing? What are some themes? Well, maybe what we can do is I'll take your theme, I'll think about cases that I've seen, we meet somewhere in the middle and build a case that has learning points, the same way a simulation would be built. So this allows you to do multi-level learning at that same point. And usually when you're doing the building of the case, you get the ability to, again, turn it into scholarly work on one end, but also you get to be as precise as you want, right? You can say these things are extremely important to learn, and so we're going to amplify it based upon the way this case is structured.
So as you think about what putting together your cases and what you want to get out of them, there's a few learning objectives to keep in mind. So one is clarity, to make sure that you have very defined objectives from somewhat the kind of outcomes you want of the case. For example, you don't have to communicate with police, or there are differences in care between people with sickle cell disease and people with cystic fibrosis. And then you want those themes to be reproducible to the, if you develop if you have different groups of learners, they'll come to some of the same conclusions, maybe not in the same way, but you still want them to have those takeaways. So now we get to do some MsED discussion, which makes me happy. But these are things you can probably look at, but I'll just quickly explain them if you haven't seen them before. So Bloom's taxonomy is a way of looking at learning that comes from a particular curriculum. On the bottom you have the learners will remember what you talked about. It might be a fact, it might be just something that is, you can repeat the information that you got. Next is understanding. They have a better understanding of why the things are the way they are. They can explain the idea or the concept. Above that you have apply, so you can take the information that you got and put it to a new circumstance and have some learnings from there. You can analyze, so you draw connections amongst the ideas. You might be starting to see a bit of a hierarchy that this workshop is a little bit based on. At the top of that, you have evaluate, so you can determine you can start to justify your decision. You can start to justify why you're making the decisions that you make. And then at the end, you can create a new or original work based off the information that you got. And so hopefully we've taken you from remembering to understanding to applying, analyzing, evaluating, and then now creating something that you can have from this that speaks to some of these principles. Knowledge, skills, attitudes is another kind of framework of competency. So are you just learning something? Do you have some skill that you can apply from it? And then how do you feel about those skills that you've learned? And that's true for central lines, and it's true for discussions about health equity. So example of learning objections would be, examples of learning objectives would be explaining race as a social construct, identifying institutionalized racism as a modifier of health outcomes, collecting and determining the influence of social determinants, social drivers of health on patient care, and applying upstander tools in clinical and non-clinical settings.
And as has been said a couple times already, it's about distilling the case to the most important concepts to you and to that moment. And so you may end up figuring out that after you run a case a couple of times, once it went in one direction and another time it went in another. And when you can identify where you had hoped to go with that, maybe it is that you're okay with it going off of to different routes, but being ready to address that would be key. But if you do have this identified pathway, then finding ways to sort of always return to that core that you wanted to get to, acknowledging everyone's contributions, but then always coming back to the critical element that you wanted to get across.
Let me add something real quick to that. One of the things that I've found is if you're picking an extremely medically complex case, you're going to drive the conversation in another direction. So I usually pick very clear pathology, or I pick a case that is socially complex, right? Because you can have levels of complexity. It's just if you're picking this patient who's got this very long course of history and all the different surgeries involved, they will get lost into that minutia, and you're really trying to make the health equity point more salient.
Right, absolutely. And so it's about having also an approach and a delivery that helps you get to that point that you're driving. So it may be about presenting information in staggered. So we did case one, had a patient A, patient B. It may be sort of presenting all of patient A first, or then presenting all of patient B afterwards. You sort of have to play with how that delivery might go, taking into account the visualization that we included, the reflection, the questions that you're asking, and how is it going to help sort of build towards that critical element that you wanted, and help you steer in that direction. One of the things that we mentioned very, very early up front was that there's some discomfort with these topics. Bless you. There's some discomfort with discussing these things, and a lot of that comes with sort of maybe you're not feeling as ready or as prepared to have these discussions. And so it does take some review of the literature, knowing sort of what terminology is appropriate to be passing along. And then acknowledging that because we are all coming from different places, part of that early part of the workshop is going to be listing those terms, making sure that we're on the same page. And then for the takeaways, sometimes you'll run out of time. Sometimes you'll maybe end up in a place you weren't necessarily sure you were going to, but having identified curated resources that then you can sort of direct your learners towards to answer some of those questions. And recognizing that it's okay if you say, that is a very important point. I'm not too familiar with that. Let's look it up later together. Then you can sort of be open to the possibility of needing to do more work yourself.
In fairness, doing this in person sometimes is a little bit more of a challenge, and there are some tools and materials that you'll be able to weave in person that are different from Zoom. When we've done this in Zoom, it's easy to drop in a link into that chat box. It's easy to say, hey, there's a follow-up here. When you're in person, it's probably going to have to be a lot more intentional, and you may want to consider some actual physical materials if that's available too. I also think a whiteboard is extremely helpful because when I've done this inside the, at the bedside, so to speak, in the fishbowl areas, writing down their ideas or collecting their values physically so they can see them is extremely helpful. So logistics are important here. I think that there's a couple ways to look at this. Obviously, you want to march this out with enough time, like lead time, to think of the ways that people might respond so that you are prepared as a facilitator. Again, the most common concern that I run into is that people feel like they are just not educated enough in certain areas to lead the full conversation, or they feel like at some point there's going to be a concern that's raised that they won't have an answer for. And so you can front load by, again, building out the case, making sure that you follow a timeline, trying to have this out, if you're going to do the rounds, start 8 weeks in advance, really try to build that case out, test drive it, see how you like it, see if there's some things that you want to improve. But also considering like what other things could come into play. Like how will you flex if, for example, your case is about women's health and then all of a sudden you hear a Twitter drop, how do you adjust for those things? How do you build that conversation and still make it safe, right? So I think that there has to be some level of intentionality. The other part that folks need to factor in is what happens on the back end. I've seen this go really, really poorly one time where at the end, the student felt bad and wasn't like fully consciously there for the shift because they were still thinking about what happened in that conversation, right? They felt somebody said something and it caused a trauma to themselves, and we had to have that conversation again about like, hey, it's okay. And so what strategies are you thinking on the front end? Do you have space to do the debrief, like physical space? Do you need a separate space? Do you need to create time for yourself? Because there is a counter-transference that can occur. You might hear something that someone says and it triggers you as well. So on the front end, try to plan for those things. And then finally, the follow-up. I think this is super helpful. There are a couple people who will be so motivated through their conversation that they'll actually do the things that you bring up. I'll give you an example. I had a student, essentially we were talking about EGFR, and I know for most folks who've kind of heard the mutterings of that conversation, some labs still collect it and display it on their charts. And so one of the students sent this email and ended up in this really long email exchange that essentially got to a point where they could no longer lead the conversation. And they were like, well, so what do I do now? Because I've asked them to do it and I want to escalate this. And I was like, dang. like you really did. I'm not the right person, but I can raise this point again. And so have a plan if someone wants to escalate or incorporate you into whatever they're so inspired to do. Cool? All right.
So some of the special considerations just to consider. So certainly incorporating some sort of evaluation into the sessions will help you both get feedback from the perspective of improving your sessions. And so like I had, first talked about, we decided to do something called appreciative inquiry, which is a little bit more comment-based and not just like a, yes, now I feel more comfortable talking about things. I think one of the things that I learned when I was getting into medical education is if you do a survey and then you teach somebody something and then you do another survey, and in the second survey they're like, yes, I learned something, that's not education, that's not good evaluation or feedback anymore. And that's what education is. That's not, the bar of medical education needs to be higher than that. So what are you actually, when you do these evaluations, what are you actually hoping to get out of it? And how does that drive the either changing of the sessions or changing of the literature around what you're doing? Which is why we decided to do appreciative inquiry. Just make sure also, you consider IRBs if you're actually studying this, or is this something that's, quality improvement? And then how do you prove to your funders or your stakeholders that what you're doing has a return on investment, right? Your time is worth doing this work. Like, it's very easy to say conceptually, like, this is important work to be doing, until it takes half your shifts away, and then you're not being clinically productive in the same way that you were, right? So you have to be able to prove that this is something that's worth it. Resident facilitators, I don't think we've actually done that yet. It's certainly something that we're considering, but it would be a very special resident, I think, who would have the maturity to lead a session like this, both from the standpoint of clinical experience, and then also ability to be psychologically safe with some of their colleagues or students. I think certainly, residents to students seems a lot more reasonable than kind of more near-peer type interaction. So I have not been able to do this. You might have, in terms of interdisciplinary teams, including other people. I think, emergency department we all love for a variety of reasons, but one of the things that I appreciate so much is the interdisciplinary team that occurs. And certainly, it's not just the physicians that need training in this, and so having the ability to bring nurses or, triage nurses, techs, case managements, and social work, et cetera, into these conversations is an awesome opportunity.
I'll give you an example briefly. So I noticed that there would be a tendency for certain types of people to get triaged a certain way. And I realized that there was also some language issues and the willingness to use a language line or an interpreter service. And so I just turned that into a case. And I asked, instead of on my day to teach, I asked the nurses to come. I asked for the social workers to come. I asked for case management to come to listen to this case, so that they could see that there was a pattern in how this happened and that there's downstream effects to it. And so after that, I realized it was more so agenda setting and awareness that it provided. What they didn't expect to happen in that was to hear how many people felt like that was harmful. Not that, but how harmful it was. And one of the persons that was there said, it really burns me up when someone opts to doesn't use the language line when I'm standing right there and I know that they should have it. And it was a person who was Spanish speaking, but was a registration individual. They were like, I use it every time, and I speak Spanish, and I do it out of the respect. And to hear that, it was so powerful for like nursing to say like, wow, this is really honoring somebody and their ability in this process. So you'll figure out that doing a joint interdisciplinary conference or an interdisciplinary team discussion like this will show you multiple perspectives, and you'll see from a clinical operations standpoint where these gaps exist in real time.
Did that person just spontaneously say that?
So when I did the collection portion, I was like, how did this make you feel and whatever? It was like, regular conversation led, and then she was vocal. She was just like, it really makes me upset. And it was weird because usually this person would not, like being invited to this conversation would not have happened. In our shop, they usually are just like floating from room to room and never asked for insight. But we set the stage so that her insight was actually like not just valued, but as equal as the doctor, as the nurse, as anyone else. And that's what this is really, why this is valuable as a tool.
And then beyond interdisciplinary teams, joint conferences with other services. So certainly we see patients who we know need to be admitted because they have new cancer, they drove 6 hours, they live in the middle of nowhere, they've never seen a doctor, and the admitting service says, well, this is clearly an outpatient workup. Outpatient workup for who? So I just think that, being able to talk about some of these issues is really important with other services. So, cool. All right, I'll let you talk.
So the last part of this is the timeline, just realizing again, start as early as you can, prep appropriately, have some materials, and if you are in person, handouts I think are helpful. Again, I'll share this part of the slide. There's actually an entire timeline breakdown that you can start 12 weeks out. You all know how to get things done. I just think that the earlier you start, the better, because as you build out the case and try to do this, you'll realize your own gaps and your own biases. You'll be like, wow, I don't have this information, or I really don't know too many other people. I'll give you a perfect example. Sometimes I realize I know a lot about an area, but I don't have an actual study to refer to. And you're like, wow, if I taught this, I wouldn't be able to give them concrete evidence about why this exists. I just know the hearsay evidence. So starting earlier allows you to do that literature review as well. The last couple of parts, and then we will do all this.
No. So the things that I think make this stand out from the lecture format or from the, hey, we did this in simulation, are some common sort of tools that are applied in different educational settings and reflective settings and debrief settings, but we want to highlight what they were, right? It's the establishing the psychological safety up front. We should be doing that with all our trainees and learners in any type of encounter where it's a teaching moment, but I think it's extra important in these types of settings to verbalize it, and then verbalize it with like a rule or a quality to it, right? Like we want you all to engage freely and we're gonna have respect, and so it's sort of qualifying that, what that safety actually means. Again, in this abridged version, we didn't have too many of the visualization episodes, but we, in the cases as they're delivered, we'll ask the trainees, the students specifically, to close their eyes, and then I'll read some of it out loud. Here we had it projected on a slide, and so it was sort of like you guys were reading it as well, but you do that visualization to get you in the space, get you to start to like feel that affective component where I remember being there just like 2 weeks ago, or I just had this patient, you know, before coming back where I had to talk to the hospitalist about it. And so there's that visualizing yourself in the space so that you can get some of that affective component to it. Sometimes the reflection is where it all starts to sort of snowball and come out, right? You start to hear what other people are saying, and it starts to develop your own thoughts, and you're finally able to say, I was feeling that, I just didn't know how to say it. Or I've thought that before, I didn't know I wasn't the only one. And so that reflective, the group reflection, but allowing enough setting for that. Contextualizing it to, you know, the settings that we're in and what we're practicing, and recognizing the limitations too, right? Like you can only go to a certain point in the roles that we have, and so adding that context of what we're bringing to it. The education component, being able to provide like, okay, not just feeling bad about it, not just sort of bringing up this long list of issues, but then thinking about the other side too. Like this is what's happening, this is what's being done, this is what we can do as individuals versus what we can do as a community. And then the brainstorming, as I mentioned earlier, try and keep in mind what has been said in this room for when you go back and you sit down and say, okay, I want to create a health equity rounds for my shop. I remember somebody bringing this up as an issue or bringing this up as a case, because sometimes it's just about that sounding board, right? You've thought about it internally, but until you can actually like explicitly express what it was, you're like stuck. It's like that writer's block, right? So the brainstorming can help a lot.
We showed this one last time. This is for your picture, folks. These are those things that I find commonly occur. We mentioned it a little earlier. We'll said it a little earlier, but these are those areas that I tend to see come up as hurdles. Make sure that you have facilitators that are trained well. Make sure that you understand the setting and environment. If you're doing it in person, like, are you going to do it in the morning or the afternoon? Is it going to be loud? Is it going to be quiet? Like, what part of the day can you do this so that you get the most from the exercise? That residual human response is hard to plan for. It's hard to have an entire, like, you know, what we do is a woosah moment or a big breath or, you know, everybody hug it out. Like, whatever your plan is, make sure you got something, because there will be someone in the room who will be emotionally charged after each one of these. Cultural situational amplifiers. I remember one time I led one of these, and I think it was right after the insurrection event. And so it was really hard to do, because every time someone said something that was a little bit not 100% like in alignment with like equity, they were, you know, you're like, okay, y'all, okay. For the individual level, this happens to me all the time. I have personal discovery throughout the cases. You know, I've run a couple of times, and I'm like, oh, someone makes a point, and you're like, man, I didn't even think about that. And it hits you really deeply. So, again, factoring that. But you can have the discovery in the other way. I really don't like this person. You know, like, you might say that. You know what I'm saying? Like, a resident might be listening to someone else, like, I don't like that person. So what is the plan around how you're going to, like, navigate that if it manifests? Triggers. I've done a lot of cases where I've seen people get triggered by the comments. Specifically, I did a case where it involved someone being apprehended, and one of the people that I was doing this presentation to, even though he was a resident, he was like, I've been arrested by the police before, and that was a lot for him. You know, so how to navigate through that trauma, you know, what that feels like at the individual level, and what you as a facilitator can do, not just to mitigate it, because you don't necessarily know it's going to happen, but how do you be there and show up for that person who feels a certain trauma response? Retaliation, as I said, a lot of times I've heard residents say, I pulled back because I didn't know if what I said was gonna be, wrong. And these are honestly, some of the residents that I wanna reach the most, the students I wanna reach the most, who may have had a different upbringing or background, and they're just saying what they thought was truth. And they never knew that would be something they would be essentially judged for. And how do you navigate that as a facilitator? Finally, the room for healing. Again, I think that using the right tone, using the right language adds to the healing and normalizing the behaviors that come afterwards. I'd like to say to people, I'm like, hey, there's a certain decay with this. Like, you're gonna sit with this for a while, and elements of it will continue to remind you. You'll meet that next patient, and then something from this conversation is going to show up. So realize that you gotta give yourself grace as you learn this as well. So, all right, y'all. I don't know what y'all bandwidth is. In my mind, we will be done. We were gonna be done a long time ago. I know everybody's sitting there like, Lord. It's just like, so here's what I was gonna suggest. And again, ideally, building these cases is a fun experience. We got two sides. I kind of want to just like sit with this side and sit with this side, and maybe loosely for a few minutes, not as long as I had up here. It was like 30 minutes on there.
Yeah,
It was like 6 minutes max. Like, or we could just talk about it, get emails, and then be on an email thread. Because hopefully what I expect you all to see is like, there's a process here. You all probably thought of a couple cases while sitting down, things that you've seen in your clinical experience. And we want to be resources in helping you while you're here. What would it look like to build that case out? Like, what should I pay attention to? So we can either do it as a group, we can talk about it, answer some questions and cut down on that full time. We can do it remotely, whichever you all feel is effective. I know some of y'all are already been in contact with, but
I would be curious if any of you have a immediate case that comes to mind that,
that you'll be willing to share.
you know.
So we had like a really poor outcome about a year ago in our waiting room, and it was basically he was 70 years old, Hispanic male, immigrated from another country, and so didn't have any health insurance, and because of that, he couldn't get into dialysis clinics. He had a history of end-stage illness. He's on hemodialysis, and this patient actually would come to the emergency department every Monday, Wednesday, Friday
their own
to get
dialysis.
his dialysis visits.
Yep.
One day while he was in the waiting room, he started complaining of shortness of breath, and that's what he presented to the emergency department for. On a typical day that he would also come for his hemodialysis. His vital signs were all normal when he arrived, and they gave him a blanket to hang out because it was going to take a couple of hours before he got his dialysis session. So they put him in a corner in the waiting room, gave him a blanket, and then about 10 hours later, someone found him dead under the blanket.
Oh,
And
Jesus.
it was a big thing, kind of triggered a awkward response to come to the hospital, and we sort of had to run. It was really interesting because the response was us running drills in the waiting room on how to do ACLS and what to do when someone was found in cardiac arrest. But I think there was a much bigger lesson sort of there, and I think there's perhaps a lot of things regarding these topics that could be embedded within a case that can be discussed with students and residents, and how we got to that point. What were the systemic issues that led to that? Not just the medicine that would occur that if you were to find someone in cardiac arrest on the waiting room.
Right.
Which
No,
was
that's
sort of
right.
focused,
Well, let's riff on that for a second.
Jesus.
Yeah.
That's like a.
That's a wow. I think that's a very good case. Again, there's multi levels to teach that at. You can go the approach of like, all right, systemic failures. Like, how do we approach these failures and shore up these areas? You can start with, well, why was it okay for him to just get a blanket and that's it in general? Lack of urgency of this condition. Because if someone else is here, shortness of breath, what's that ESI number looking like? Was he an ESI 4 because they knew him, or was he an ESI 2 because of shortness of breath on dialysis, right? Like there's all these different areas that you can explore. And then there's a component like, I don't know what his ethnicity is, but did they actually talk to this patient? Did they get the information from him in his language and as critical as the patient was making it out to be, right? Those are the ways that I would approach this. And then I would start with, all right, what am I teaching from this? What do I want people to walk away from? It's not that, hey, don't give people in the lobby blankets, or, hey, just because you come to the ED for dialysis doesn't mean that there's not another condition going on, because that's to me more medical, right? The equity cases, how many people come to this emergency department and get treated like their condition matters? Now, why did we treat this one differently this particular time? What about this presentation was like, okay, we can chill? And then who was responsible? What were the roles involved to know that this was wrong? And how do we miss that? How do we create systems to say, all right, this patient needs to be seen? Who feels comfortable telling someone and escalating it until they get seen? So I might come at it from that angle and show that case.
Yeah, with something of this valence, right? It might be because it's triggering. For a lot of different reasons, it's going to be triggering because of the bad outcome that was had. It makes more sense to start at the learning outcomes that people are supposed to walk away and then build back from that. It's a very common, ed curriculum technique. But then you also have to ask yourself, how much of that anger, frustration, affects do you want to make a component of each of those pieces? Because it's very angering, right? But if you don't want to get lost in those emotions, then that's where the coming up with the discrete learning outcomes helps as well, so that you can refunnel to those. But if what you're going for is that affect, then you sort of incorporate the comparisons. Why this versus not the other? Why in this patient, not the other, right? And you highlight the differences to sort of amplify that emotion. So you have to have this idea of how much is that going to play into?
I think it's easy to argue that the failure is not even that day. It's every single other day.
Right.
It was an actual thing.
Yeah.
Okay.
Yeah, I'm just curious how you all deal with because what comes up for me in cases like this is there's our health insurance system is broken. Why do people have end-stage renal disease? Why, the immigration crisis, all sorts of things that as a physician, or especially as a resident, I might not have immediate power to affect change in, although I want to. So hearing these cases just makes me feel stressed out and vulnerable and what am I doing with my life? And I remember that as a medical student too, having the separation between okay, well, what are the things, different levels of ways to affect change? I feel like what we've been talking about a lot today is how do we provide equitable care within our sphere of influence in the emergency department, and separating that out from how do we provide equitable care as a society and affect the social determinants of health, which kind of feels unwieldy. But I guess I'm appreciating that you are focusing more on what can we do in the clinical sphere. I'm just wondering are there specific ways that you address that, or how do you parse that out when you're talking about these things?
I literally list each level. So I'm local, institutional, local, state, federal, national, whatever. And then what I do is I brainstorm again ahead of time one action that I would be able to give them as kind of a prompt, so that they can start thinking. Because what you'll find is in every group there's someone who's okay, I used to I go to the Hill and advocate or whatever. They have their little advocacy arm. And there's someone who's I work in this organization at the regional level. So there's folks at these places, and they just need to know what the marching orders are. So your job as a facilitator is to kind of help paint that picture. Say, it's not, if you just only have energy to do something right at this institution, what does that look like? If that's, okay, so we're going to create policies where ESI levels are assigned differently, or we're going to make sure we do checks on anyone who's been here longer than 90 minutes. Whatever those policies are, you're going to create that. Then at the state level, you're all right, so why are there, what is the immigration state-based funds or resources for people who need to go dialysis? What are those centers like? So you build out each level for them, and then you prompt them to kind of all right, add what you have. If you're someone who, and this is, I think I think at all of those levels all the time. If you have limited, time to do this, then I think it would make sense to tell somebody all right, I'm available afterwards for discussion on those two levels that are a little bit deeper. Because those top two ones, meaning the institution and local, are what they're going to do. those are ones that absolutely, I've never heard anyone come back to me and be like, yeah, so what I did was I led a march. Like, no one has done that to me for me yet. Like, no one has been like, so on Tuesday, it's going down. I haven't had that yet. So I get the people who are like, I sent the email, I'm doing this as a QI project. I went to the state, to our community board meeting and told them to form this advisory board. That's what I get.
And I think it goes to the learner level or the trainee level, right? You can almost push the ask a little bit higher of the residents. Hey, I want you to think about the QI project that's going to come from this, right? Whereas the med student, it might only be rotating with you a couple of weeks, few weeks. It's like, I want you to engage in that reflection at the end and tell me like how that's something that you walked away with that was different, or right? And so that might be more on the knowledge aspect and level. And then of course when we have trainees and that are a little bit further or more engaged, the clinician that's been practicing for a while, it's like, okay, let's start looking like, what's that next step, right? Like, we're not about the QI project anymore. It's about like, hey, let's look within our department and what needs to change within our department, what needs to change at the institution.
I also use the elevator pitch as a strategy as well. So if I want them to think at the level of national or state, I'm like, so what's your 30-second pitch to make somebody believe that this issue is mattering, is important? What's your 1 minute pitch? You tell me what you would say. Like, that's a tool to get them engaged in how they would do it at the, walk into a state house or into a Capitol building.
I think to some degree it's just confronting the fact that this exists and is a reason for, is an okay outcome. It doesn't have to be, not everyone has to go out and be inspired, but like that it's, that you can confront these problems and then you don't have to, I won't say you don't necessarily have to do something about it. Obviously, we're hoping that, people are inspired, even if it's just holding more exercises like this. But like, I think in medicine, like you said, the focus is on the clinical care, not like what actually is some of the underlying reasons. And that's like, in my head, that's an okay, that's a good outcome too.
But also normalizing that if that's all you have the bandwidth to do, it's okay. Just being a good physician that understands that this is important will help somebody. So it's always about reframing it in terms of what the learning objectives are and how they walk away with it. Everybody's not going to leave one of these and start an organization. That's not going to happen. But for the person who is motivated to do so, like, being able to voice that is also important.
I think my goal of trying to change in my program is to make people, residents aware, because they're going to be the future, standing here, and so you can inspire. You're here, but my residents that came to SAM, I'm the only one in this one, right? I won in that one on women and sex gender, which is great. And I'm going to go to both, and I'm gonna, but the other residents, so trying to create that change so that they're aware when they're attending, so they can stop those biases. When they'll be running departments and wherever ERs are working, hopefully they can help, because we don't all necessarily go to academic programs after residents.
True.
And those community hospitals, they're not motivated by academic reasons to do these types of changes. And I think it's important for all residents to undergo some type of awareness training.
I'm going to add this to that part. It's interesting. So I've run these, when I talk about doing these other places, I've done a lot with community sites, like where they want their docs to understand how to understand these biases. And you get entirely different outputs when you do that. But when we get to the reflection part, it's almost the same type of behaviors. Everybody really feels, and then, or the commonalities, and then at the very end, when we ask people to brainstorm, by the time we get there, most folks are locked in and engaged and thinking of what they can individually do on the next shift. That's where they're like, what can I do on the very next shift that's going to improve something like this?
And it's a little bit of like the train the trainer model or trickle effect, where you're reducing some barriers, right? Like, they didn't sign up for this workshop maybe because they didn't come prepared to be like, I'm going to do a pre-day workshop, right? But if it comes to them, it's not that they wouldn't engage with it. Like, they might have been put here and then engaged just as much, but it wasn't in the to be. It wasn't meant to happen that day, right? But when you reduce the barrier and it comes to you and you're exposed to it, you go, yeah, okay, I'll engage. And so sometimes it's about that, about the positioning and the availability.
Indeed. Cool. All right, y'all. I I want to give y'all the rest of y'all day, but I'm gonna hang around for a little longer for talking. If it's all right with y'all, go ahead
That's
and
totally
close it out.
fine. We can exchange
This is-
emails too
So,
and keep that going.
Yeah. First, I want to thank. To give you all full context and background, I've been studying this stuff for a little while, and both of these gentlemen gave me the opportunity to try it. And I'm grateful for both of you all creating that space, and among that, we've really created a synergy in doing this. And my hope is that whatever you learn here today, if there's something that you can take back to your shop that's useful, employ it. There's an open, email policy. If you have questions, you want to borrow some cases that we already have, I'm happy to give it. I'm not using this as a scholarly work. If anyone else has greater understanding of how to do that and would like to collaborate on it, I'm down. But I just want to see, health equity elevated into an absolute, undeniable feature of clinical care. Like, that's it. That's my entire buy-in. But no, for real, this has been fun, and thank y'all for coming.
Thank you very much.